Good morning, everyone. This is my name is Ramana Moorthy, but I go by Bob, and I'm going to talk to you a little bit about an update on management of uveitis that has changed a little bit, so that everyone will be kind of brought to kind of what we're doing in the U.S. in part, so it's maybe a little U.S. centric, but I think it has some international studies as well, and we'll talk a little bit about uveitis management. So I know there are I looked at the some of the questions, and I've looked at the people that are joining the webinar and so forth, and I know that the various stages of learning about uveitis. Some of you are experts and far smarter than I am, I'm sure. And some of you are beginning your training perhaps and beginning to understand about uveitis. So I'm going to spend just a very few minutes, and I'm going to move quickly. So there's a recording available, and I apologize if I'm talk too quickly. I will try not to do that, but you can always review this talk. So let me start by telling you the basics here. I don't have any financial disclosures to report. So the purpose of the uveitis evaluation really is to assess the situation, of what the patient has, find the cause of the inflammation, whether it's infectious or non-infectious, and identify what the best treatment is, and tell them about the prognosis. And the most important thing about the uveitis patient is taking a good history, because if you don't take a good history, you'll continuously be lost as to what's going on with the patient. So really digging into the depths of their history of present illness, their past medical history, their surgical history, and about their symptoms, specifically, when did it start? What kind of problems are you having? How often are these symptoms coming back? Are they recurrent? Are they chronic? What other illnesses, other problems that may be related do we need to know about? Are there skin findings like zoster or granuloma annulare or lupus pernio or erythema nodosum or vitiligo or poliosis that potentially could be issues? Are there mucous membrane lesions like the Behçet's patients with oral aphthous ulcers? Are there pulmonary symptoms indicating that the patient may have very bad sarcoidosis, like in this picture? Are there gastrointestinal symptoms suggesting inflammatory bowel disease, or possibly even rare things like Whipple disease? Are there symptoms that in the genitourinary system, musculoskeletal system, particularly patterns of arthritis that may clue you in as to autoimmune arthritic conditions? Are there exposure to zoonotic or arthropodic vectors like cats, biting insects, etc.? Travel history, especially knowing the endemic diseases that are present in certain areas of the world, can be very helpful in teasing out the cause. Then we move to the examination, and the most important tool in the examination is the thing in the center of your brain. So if you don't use your brain when you do the examination, it doesn't matter. You can have millions of dollars invested in imaging and equipment, but you got to have a good brain to use and put the findings together. And you need a slit lamp examination. It's very, very important. I'm sorry, it's in Spanish. Maybe this is to kind of go with the international flair of this talk, but the slit lamp is very important. The slit lamp tells you how much inflammation there is, because eyes can be white and quiet. They don't always have to be red when there's inflammation, So there's a lot of it. So for example, pediatric uveitis, the eye will be white and quiet externally. You won't be able to tell anything. And it's only with microscopic examination of cells in the anterior chamber using a slit lamp with a high intensity beam, with a 1 by 2 millimeter beam, looking at the anterior chamber and assessing cells, that you'll be able to tell activity. Cells and flare in the anterior chamber important. Looking at posterior synechia formation for anatomic structural complications from chronic inflammation. All that is super important. And looking at the back of the eye cannot be overemphasized, because you don't want to miss things in the back of the eye. Just because there's inflammation in the front doesn't mean your examination stops there. Right? There are things going on in the back of the eye that will tell you additional information and give you clues as to what the cause of the inflammation may be. So the uveitis specialist, more than any other, is a master of the ophthalmic and, in some cases, the systemic examination. So you got to look at the whole patient. Okay, I'm not going to go through the details of all of this. You guys are all experts at this, but it's very important to assess the conjunctiva for conjunctival nodules, cornea, anterior chamber cell and flare, the iris for the presence of inflammatory nodules, peripheral anterior synechia, posterior synechia. Gonioscopy is often forgotten and very important, looking at the lens for inflammatory membranes and posterior subcapsular cataracts. Remember, acute inflammation will show up as red, painful eye. Intraocular pressures may be low. There may or may not be posterior synechia, but there can be a hypopion or fibrin in the anterior chamber. Chronic inflammation, they look white and quiet, but there's lots of structural damage like you see in the picture to the right here with synechia present to the lens and inflammatory nodules on the iris. Look at the vitreous. Determine the amounts of cells and haze. There's not great grading systems for vitreous cells, but there are some grading systems for haze that you can use. Look at the retina and the choroid and the optic nerve. Look for optic nerve edema. Look for optic nerve lesions, cupping, pallor. Look for in the retina for inflammatory lesions, retinal vascular lesions, retinal hemorrhages, cotton wool spots, vascular sheathing, presence of macular edema, cystoid macular edema, presence of secondary complications like choroidal neovascularization or neovascularization. Those kinds of things can be helpful, give you clues as what's going on. Yes, you have to look at the other parts of the body on the exam too, the skin, the mucosa, joints, and things that I've already talked about. If you're still not sure after doing the full examination of the patient, you kind of rely on patterns of recognition. You know, there are certain patterns of disease. For example, the patient in the upper left has zoster, and they have zoster-related inflammation in the eye. The patient in the middle has evidence of a syphilitic rash with a palmar rash, and the patient on the bottom right has Lyme borreliosis with the typical erythema chronicum migrans type thing. You can look at this. This is a patient after cataract surgery who has a hypopion. That uveitis is an endophthalmitis until proven otherwise. This is treated with, it's a surgical problem, needs to be treated with intravitreal antibiotics. Sometimes the vitritis can be very severe and you can grade the vitritis, and looking in the back of the eye can be difficult. So then you have to use an ultrasound machine or some other agent. Sometimes it can be very easy looking at a single area of focal choroiditis associated with retinal vascular sheathing adjacent to retinal choroiditis indicates toxoplasmosis in most cases. Here's patients with tuberculosis. In certain parts of the world, TB, uveitis is very important to recognize, and there are very different variations of tuberculous uveitis that can be quite severe. Bartonellosis is also a common infectious uveitis condition. Patients who are immunocompromised or who have AIDS in certain parts of the world, we still have high numbers of patients who have AIDS, and looking for cytomegalovirus retinitis and recognizing the pattern for that is very important. Necrotizing herpetic retinitis can occur in the immunocompetent as well as the immunocompromised individuals caused by zoster or HSV. You also don't want to miss the findings in the sclera. For example, a patient who presents to you like this with the necrotizing area of scleritis that's very painful has, you have to look for the positive possibility of underlying systemic vasculitides. Then you rely on additional data by getting imaging, fluorescein angiography, OCTs, ultrasounds, all of these things. If you have those tools available, great. You don't necessarily need all those tools all the time, but they can be so helpful today to look at the macula, to look at the retina and assess things. And really to do a really thorough assessment for uveitis, often you need these to help you. Then you put it all together. Put it all together in a single statement, like you have on the top here. A 27-year-old male, for example, with a hypopion uveitis, with metacarpophalangeal joint tenderness and redness, and patchy psoriatic skin rash over the extensive surfaces. So this patient who has unilateral uveitis like this condition, I can tell you the diagnostics are very small here. I would get 2 tests on that patient, an HLA-B27 and an FDA. And that patient most likely has HLA-B27 associated uveitis, probably associated with reactive arthritis or some form of seronegative spondyloarthropathy. So it has to be, for looking for the etiology, it has to be problem focused, right? You don't want to be kind of doing $1 million lab workup and getting things like CBCs or, getting a SED rate or CRP, which is kind of useless information unless you have some reason to get that. If you think of something that you forgot based on your exam or imaging, go back, ask questions, look again, because this is a workup of the uveitis patient is a work in progress. And the laboratory testing is only supportive of what your presumptive diagnosis is. It's not a substitute for your exam. It's definitely not a substitute for your history. And remember, you get more than one chance to work up the uveitis patients because many of these patients have chronic diseases So and they have significant severe vision loss. They need to be monitored and treated very carefully and monitored closely and recurrently. Don't order tests that are not going to help you. Lupus and rheumatoid arthritis are clinical diagnoses, and labs such as ANA and rheumatoid factor are not part of the uveitis workup in adult patients unless the patient has scleritis or retinal vasculitis. It is part of the workup for patients with chronic uveitis who are children, because we want to rule out juvenile idiopathic arthritis and determine the subtype. But I almost never order an adult patient an ANA or rheumatoid factor unless they have scleritis or retinal vasculitis. And if a patient has a hypopian anterior uveitis, you don't want to order HLA-A29 testing. It's useless, right? You want to order HLA-B27 and maybe an anti-treponemal IgG, because 5 to 8% of patients are going to be HLA-A29 positive. It only means something when the clinical findings of birdshot retinochoroiditis correlate with the A29, when it fits together. There are other invasive testing that you can do that we'll cover in just a little bit more in our updates. This includes anterior chamber tap or vitreous tap, and performing polymerase chain reaction studies, looking for DNA fingerprinting of infectious agents that may be causing the uveitis. And more advanced techniques like retinochoroidal biopsies that are really part of the uveitis and retina specialist armamentarium. There are diagnoses of uveitis that you don't want to miss. You don't want to miss infectious causes of uveitis. You don't want to miss necrotizing herpetic retinitis, because that causes blindness very quickly. You don't want to miss syphilis, because it has tremendous, not only social implications, but significant neurologic and life implications. You don't want to miss the diagnosis of tuberculous uveitis, because it has systemic and life implications. You don't want to miss the diagnosis of systemic vasculitides, like that patient with the scleritis, necrotizing scleritis that I showed you, because those patients have very significant increase in mortality, not just morbidity, but mortality when the disease process is not treated. You don't want to miss the diagnosis of primary CNS lymphoma, which is a masquerade syndrome for uveitis, because that can kill somebody very quickly if you miss that diagnosis. And you don't want to miss the diagnosis of other things like cancers that may masquerade as inflammation or inflammatory paraneoplastic syndromes. And then you don't want to miss other things that look like uveitis that aren't uveitis at all. Things like chronic retinal detachments or hereditary retinal dystrophies, because they can be the detachments are treated with surgery and you get them fixed. Hereditary retinal dystrophies are treated very differently, if at all. So these are very important things to know. So let's start with the first polling question. What is the most important reason for performing a diagnostic workup of a uveitis patient? So is it to determine the etiology, if the etiology is autoimmune? Is it to determine if topical steroids can be used safely? Is it to determine if systemic immunosuppressives are needed? Or is it to determine if the etiology is infectious or non-infectious? Okay, so good, excellent. So that's right. The most important thing that we want to know is if it's infectious or non-infectious. So I'm glad that you guys are awake and paying attention. Here in Indiana, it's about 9 o'clock. So I've been up since 5, but you guys are probably in the middle of the day or later in the day. I hope you're not too tired. Let's keep moving on here. So what are the things? So this is important, right? We want to look at we want to know the diagnostics, and from the diagnostics, what's the cause? So what are the advances that have happened in diagnostics? Polymerase chain reactions were first described in 1985, where we can amplify small regions of the DNA. And now we have things automated to the level that we can do tremendous and very quick analysis qualitatively and quantitatively. In the field, even in places that are very remote in our world, we have access to small, very simple machines that do sophisticated analysis of sputum samples, for example, to determine if the patient has Mycobacterium TB, right? I think many of you may be using that in your clinics to determine, and very quickly using the PCR techniques to amplify small pieces of DNA that may be present without having to do very complicated and very significant long cultures that take a long time to get back results. So we know immediately. Sometimes we can even speciate the organisms based on the DNA findings. So beyond that, in the last 10 years, we have had tremendous advances in the development of what we call multiplex PCR. We can detect many different target genomic DNAs at one time, sometimes in the hundreds or even thousands, and they have high sensitivity, but they also have high false positivity because they're pick up so little tiny, bits of DNA. So it's really, you have to use this with a grain of salt when you're evaluating this. There's also real-time PCR, and this is what I'm talking about when you're looking at 16S ribosomal DNA, ribosomal RNA pieces, and conserving, using conserved genomic regions of different species of bacteria like mycobacteria and fungi in the field, and making a very rapid real-time diagnosis. And finally, within the last 7 or 8 years, metagenomic deep sequencing is a field in itself, where we can use basically a big shotgun approach and look at a broad identification of all possible pathogens in a sample. But these need primers from a large data bank, but they provide rapid diagnosis, but they provide also tremendous clues and can be forensically evaluate the cause of a uveitis. A uveitis that may be chronic, lasting 50 years, we may be able to go back to the inciting event in some cases, which is quite remarkable. That requires the skill of somebody who has a lot of experience in metagenomic deep sequencing and access to very, very big data sets and complicated equipment. So this may not be immediately available to us, but I suspect in the next 10 to 15 years, we'll be seeing machines and laboratories that will be able to do this regionally in many parts of the world. So how do we use this in practice? Well, in one study, for example, aqueous and vitreous samples of 9 common infectious uveitic pathogens were evaluated, and they found that specificities and sensitivities were very, very high. And the intent of the authors was to use real-time PCR and provide high level of fidelity and correlate it to quantitative PCR, which takes a lot more instrumentation and techniques. And that's what they found, that in the field, you can do a multiplex PCR strip and within a few minutes or even an hour, find the cause of the inflammation, where it used to take days sometimes to do it. So that's where we're going with this. I'm going to now switch bases here a little bit and talk a little bit about what most of this rest of this talk is going to be. In the developing world, that you all know outside of the US and the Western world, for example, that the most common cause of uveitis is probably infectious, right? So you don't want to miss infections. You don't want to miss syphilis, tuberculosis, toxoplasmosis, okay? You don't want to miss also regional infectious problems, right? But the mundane day-to-day activity for me in my practice is the treatment of non-infectious chronic ocular inflammatory diseases. Why is that? Because chronic inflammatory diseases are incredibly frustrating, very difficult to treat, and often require the expertise of somebody who has some experience in ocular immunology, in the use of things that are steroid sparing. Steroids by themselves aren't the final answer, although they're an initial step for the treatment of these patients. So once we know that the uveitis is not infectious, and we know that it's not caused by an infectious organism, our treatment is different. If you have an infectious causes uveitis, how do you treat infections? You treat them with antibiotics, right? That's the most important thing to remember, that if you have somebody who has infectious uveitis and you give them a lot of steroids, they're going to get worse. In general, that is the case. And there may be some exceptions, but in general, in the long term, or in most cases in the short term, they're going to get a lot worse if you miss the diagnosis of infectious uveitis. So it's very important to make sure that you understand if it's infectious or not. And that's why you have to do those laboratory testing to help you, serologic testing, and sometimes aqueous sample testing, depending on what you think it is. Okay. Then once you know that it's non-infection, that it's not an infection, then you can move on to treatment. So treatment guidelines are that once you know it's non-infectious, the paradigm is to control the inflammation that is non-infectious and eliminate the risk to the vision and try to avoid structural complications of the disease. The choice of the agent that you use initially is based on the specific diagnosis, the current ocular systemic disease, and existing level of ocular function compromise, and whether they have bilateral disease or unilateral disease, and also what the desires of the patient may be, okay? Now, the initial therapy is to control inflammation rapidly, okay, when somebody presents to you, when they have non-infectious uveitis, particularly in the acute uveitis cases versus chronic, but regardless, the goal is to control inflammation rapidly. That means using corticosteroids for the most part. There are rare exceptions to that. Corticosteroids are the most effective agents to get the inflammation controlled quickly. And this can be administered topically, regionally, and systemically. Regional use of corticosteroids, you have to be very careful because you don't want to give regional or, for example, periocular or intraocular corticosteroids for somebody who has an infectious uveitis like necrotizing herpetic retinitis caused by varicella zoster virus or herpes virus. If you give them intravitreal triamcinolone, the eye will be blind and never recover. Okay, so it's very important in those cases that they be on antibiotics first and be treated with antibiotics before you start covering them with more aggressive corticosteroids and when it's infectious. But again, we're talking about non-infectious uveitis now. Corticosteroids are the most effective way to control inflammation quickly. So, the multi-center uveitis steroid treatment trial looked at both local steroid triamcinolone, the fluocinolone acetonide implant versus systemic anti-inflammatory therapy of steroids. And I'll go over the results, some final results from that. But this showed us that both can be fairly effective in controlling not only the inflammatory disease, but complications like macular edema. But there are caveats to both of these, quality of life caveats and complications caveats from corticosteroids. So for certain conditions such as mild scleritis, et cetera, you don't need to use corticosteroids. You can get away with non-steroidal and anti-inflammatory medications. There are certain cases, certain disease processes where early initiation of immunomodulatory steroid-sparing agents is very important. I told you, remember, that steroids are the quickest way to get inflammation under control. There is an exception to that. Patients who have explosive onset posterior segment disease associated with Behçet's disease, and some of our friends and colleagues in Eastern Europe and India and in Southeast Asia who see a lot of Behçet's disease know that the treatment of Behçet's, especially explosive posterior uveitis from Behçet's retinal vasculitis, the best way to get the inflammation under control is actually with intravenous Remicade or infliximab infusions. Infliximab and infliximab biosimilars can be very effective in controlling inflammation, and oftentimes they can be even faster than corticosteroids in controlling the inflammation of Behçet's disease. And there are other cases where immunomodulatory therapy becomes very important to eventually utilize, but steroids are still initially utilized as an initial step. Sympathetic ophthalmia, necrotizing scleritis, serpiginous choroiditis, birdshot retinochoroiditis, juvenile idiopathic arthritis, all of these things, chronic VKH, all of these things require immunomodulatory therapy ultimately. With steroids, you start high and gradually taper. That includes topical steroids. So for example, if somebody has a lot of anterior uveitis that's non-infectious, you want to put those patients on, when you initially see them, topical prednisolone drops or steroid drops every hour and gradually taper those drops over the course of probably many months. You can't taper them very quickly if they have severe inflammation, because if the inflammation gets under control, or the patient reports that, oh, my symptoms went away, the inflammation is still there. It will take a long time for severe inflammation to gradually decrease. It may take at least 2 to 3 months for severe inflammation to decrease in the anterior chamber for non-infectious uveitis. So tapering of those steroids is done very gradually. And if the disease activity occurs when you taper, you have to look at the dose of the steroid that you're on to determine what the next step is. If you're on oral steroids and you're started at 60 milligrams a day and they flare at 20 milligrams a day, well, they're probably not going to do well on steroids alone, and they may require immunosuppressive therapy. So when you can't control them with the first line corticosteroid therapy, then you think about using immunosuppressive medications. There are multiple classes of drugs for immunosuppression that we'll get to. And these include antimetabolites, calcineurin inhibitors, alkylating agents, biologic response modifiers. All of these things are talks in themselves, and I don't have a lot of time to go over each one of these. There are lectures that I have given about each one of these that you can see in the Orbis database. But beyond the second line therapy, then our options become more severely limited because some of the drugs that we use are off-label in these cases. And then we have also combination drug therapy or sometimes surgical therapy in uveitic patients. There are special considerations for the use of these non-steroid medications, for example, in pregnancy and people who are of childbearing age, and also vaccine recommendations are particularly important because if they're on immunosuppressive therapy, you should probably not take live viral vaccines such as the oral polio vaccine, or now the varicella zoster doesn't apply now because it's been replaced by a killed viral antigen vaccine. Rabies vaccination and influenza vaccine sometimes involves a live virus. You want to avoid that in patients who are immunosuppressed. So the updates really in the management of uveitis come from the MUST trial done in the United States, the and a broad multi-center uveitis steroid treatment trial, and also the systemic immunosuppressive therapy for eye diseases trial, a site cohort study, which is a retrospective study. The MUST trial is a randomized controlled clinical trial comparing systemic therapy to the fluocinolone implant. And then the systemic immunosuppressive site cohort study is a retrospective study looking at specific therapies, complications, and mortality and morbidity. Let me ask you the first question, and then I'll show you the answer. The next polling question: which of the following statements are true regarding corticosteroid therapy for non-infectious uveitis? Number one, fluocinolone intravitreal steroid implant provides superior quality of life compared to systemic immunosuppressive therapy. This is for non-infectious uveitis. The second is periocular corticosteroids are more likely to cause significant intraocular pressure elevations compared to intravitreal dexamethasone implant. Number three, all local periocular or intravitreal corticosteroid therapies can cause IOP elevation. And then finally, corticosteroid therapy is not the first-line therapy for non-infectious uveitis. That's right. All corticosteroid therapies, every one of them can actually cause intraocular pressure elevations. So I have seen patients after periocular corticosteroid injection develop intraocular pressure elevation 10 years after their last injection and develop really severe, rapidly progressive glaucoma. Now, can I blame my periocular corticosteroid injection alone? Maybe. But maybe the patient had a propensity to develop glaucoma from a family history or family genetic propensity. But regardless, once you give regional corticosteroids, for example, or even oral corticosteroids, you may change structurally the trabecular meshwork permanently in some cases. And those patients may go on to have a lifetime risk of glaucoma and need to be monitored carefully, even after their uveitis goes into quiescence, and even many years after the patient has stopped the corticosteroids. So it's very important to keep that in mind. What the MUST steroid implant trial ultimately showed is that at the 7-year mark, and now we have even longer data, that systemic therapy provided better visual, especially steroids with immunomodulatory therapy, better visual outcome at 7 years compared to the fluocinolone implant with very comparable quality of life and safety data. That's important to remember. So long-term, patients did well with either therapy, but steroids plus immunosuppressive oral steroids and immunomodulatory therapy together, low-dose oral steroids, of course, but the combination of immunomodulatory therapy and steroids worked very well, provided reasonably good quality of life comparable to the fluocinolone implant, and had better visual outcomes than the steroid implant alone. The steroid implant is very important because we have two types of steroid implants now, right? The Retisert implant, which is the trademark from Bausch & Lomb's fluocinolone acetonide implant, that's a large dose implant, is very different than the fluocinolone acetonide insert or 0.18 implant, which is YUTIQ. The 0.19 Iluvien is not used for uveitis. It's used for macular edema from diabetes, for example. But the YUTIQ is used for a non-infectious intermediate posterior pan uveitis. And this is not approved for anterior uveitis, by the way. So this is non-infectious intermediate posterior uveitis. When utilized, the YUTIQ implant provides significant greater duration to the first recurrence. We're talking about a 10-fold, almost 657 days to first recurrence after implantation compared to 70 days with sham injection and using oral steroids. There are fewer recurrences with the implant at 36 months after insertion. and it significant reduces macular edema, but it does cause more frequent cataracts. And glaucoma with this lower dose implant seemed to be comparable to the sham group. I wouldn't say it's less frequent. It seemed less frequent in the studies, but likely it's comparable and didn't seem to make a huge difference in glaucoma development, although intraocular pressures should be measured in these patients. So this is an implant that lasts 3 years that you can implant in the office. Many of you may have done this, the Uveitis implant, which is the trademark name, with the fluocinolone acetonide 0.18 implant. This can be utilized and is shown in a large randomized clinical trial to be highly effective in the treatment of non-infectious intermediate posterior panuveitis. The POINT trial, this is a trial that evaluated the efficacy of 3 regional corticosteroid injections for uveitic macular edema, 3 types of regional corticosteroid injection approaches: the periocular triamcinolone, the intravitreal triamcinolone acetonide injection, and the intravitreal dexamethasone implant. What the bottom line for this study is that intravitreal triamcinolone acetonide and the intravitreal dexamethasone implant were superior to the periocular corticosteroid implant for the treatment of uveitic macular edema. All of them caused intraocular pressure elevations, but the intraocular pressure elevations were greatest for the intravitreal treatments. And there was not much difference between the 2 intravitreal treatments. You needed fewer injections, it looked like, to control inflammation in the intravitreal groups compared to the periocular groups. So, but all of the treatments did improve vision and improved central subfield thickness in the treatment of uveitic macular edema. Next polling questions. This is an update question. Steroid-sparing immunosuppressive agents increased risk of cancer mortality. True or false? So this is very interesting. Goes back to what the results tell me, that what we have in the treatment paradigm as uveitis specialists in the treatment of non-infectious uveitis still needs to be we need to kind of toot our horns here, because the use of steroid-sparing immunosuppressive medications in the treatment of non-infectious uveitis has been shown to not increase cancer mortality. The old paradigm was, oh, you're poisoning patients when you treat them with these immunomodulatory agents. But these immunomodulatory agents indeed are generally very safe when monitored appropriately and taken care of appropriately for patients and administered appropriately. And they tend to be very well tolerated some have virtually no risk. Methotrexate, for example, when utilized, has 0 risk of cancer-associated mortality and secondary cancers in general. The other agents are very, very low risk. How do we know that? Well, we know that from a large cohort from the SITE studies. So what the SITE studies showed us is that, that azathioprine, methotrexate, mycophenolate, cyclosporin, systemic corticosteroids, or dapsone had overall cancer incidence rates and cancer mortality rates similar to that of patients who never took immunosuppressive medications. Isn't that amazing? So, but there are agents that we use that are pretty toxic, like cyclophosphamide. That drug, the overall mortality, remarkably, in the case when we use it for in a non-infectious uveitis, was not increased, and cancer mortality was not significantly increased to those who didn't get it. Isn't that interesting? So when we use it appropriately, when it's given appropriately, and there are guidelines for use of agents like cyclophosphamide that help us. Tumor necrosis factor inhibitors were, however, associated with the slightly adjusted overall hazard ratio about 2 times greater for overall risk and cancer mortality. So there is some increased risk of cancer mortality associated with tumor necrosis factor inhibitors like adalimumab and infliximab. Next polling question. Which of the following clinical features of chronic anterior uveitis is determinant of reduced rate of disease remission? Excuse me. I think I'll go forward here. Sorry. And so which is associated with reduced rates of disease remission, longer duration of disease at presentation, unilateral disease, older age at presentation, or absence of underlying systemic disease? This is a tough question. So let's see what people think. So in patients who have chronic anterior uveitis, that means they have the externally white and quiet eyes, but they may have chronic inflammation. So that's right. And so, the features that really are a determinant for reduced rates of disease remission, that means they're unlikely to go into remission, are if they have longer duration of disease at presentation. In other words, they've had the disease for many years. When they come and see a uveitis specialist, those folks are not going to do well. There are other factors too that I'll review with you in some of the studies that were, some of the site studies and other studies that have shown what these predictors are of remission. But it turns out that bilateral disease, younger age at presentation because they have to live with their disease longer, and systemic disease associations like JIA or spondyloarthropathies, those kinds of things, those kinds of autoimmune disease processes in non-infectious anterior uveitis tend to be bad prognostic indicators in terms of disease remission. So those patients don't go into remission. Here we go. So how do we know that? The site study that was published in 2019 recently looked at this particular issue, okay? About a third of all of the patients, 2,795 eyes and 1,634 patients remitted within 5 years. But the 2/3 that had reduced remission incidence, they looked at very carefully. And those patients who had reduced remission incidence had a longer duration of disease, were more often bilateral, more often had structural complications, like presentation in particular, and required surgical intervention. And they were younger at presentation, and these patients often had a systemic diagnosis associated with their inflammatory disease, specifically things like JIA or spondyloarthropathy. So those patients, when they're on immunosuppressive therapy, they may need to stay on immunosuppressive therapy for many, many, many years, sometimes 10, 15, 20 years, maybe lifetime in some cases. I have now, after being in practice for more than 30 years, I have patients who I saw as children now coming back as adults having inflammatory problems when they have very severe uveitis as children. So this is very important to keep in mind that, bad diseases, chronic inflammatory diseases, tend to not necessarily burn out or go away completely. There are many agents that we use to spare the use of steroids, antimetabolites like methotrexate and azathioprine and mycophenolate are the first line drugs for immunosuppressive therapy. And what do we know about these antimetabolites? Well, one of the things that was done that was a remarkable study that has been updated in 2022 is called the FAST trial. Many of you may have participated in that trial in India and here in the US and abroad, but this trial was remarkable because they looked at a steroid taper, and patients then were randomized to either methotrexate or mycophenolate as the agent to try to spare the use of corticosteroid as the steroid was tapered. At 1 year, it looked like methotrexate was a little bit more advantageous than mycophenolate in terms of treatment success of achieving less than or equal to 7.5 milligrams per day of oral corticosteroids or 2 drops of topical prednisolone with very, very little active inflammation. It looked like the methotrexate group was having a little bit more success in this study, but in follow-up evaluation 3 years later, what we found is that the time to reach treatment success defined as less than 7.5 milligrams a day, less than or equal to 7.5 milligrams daily of prednisone maintenance for chronic intermediate posterior panuveitis was the equal for both methotrexate and mycophenolate. So both drugs can be utilized and are highly effective in getting the inflammatory disease under control and minimizing the need for oral corticosteroids. And both appear to be equally effective in controlling inflammation, and both allow reduction of prednisone to maintenance doses of 7.5. This is 7.5 milligrams a day or less. This is really important information for the uveitis specialist who's relying on these agents. So you can choose the agent based on tolerability of how the patient and the patient's individual choice. Sometimes we may have a favorite medicine that we use, and it's purely up to the practicing uveitis specialist to determine this. So there are other agents that we use less frequently, like calcineurin inhibitors, like cyclosporin and tacrolimus. And of course, these heavy-duty agents like alkylating agents like chlorambucil and cyclophosphamide are used for really bad types of uveitis, like necrotizing scleritis, for example, or serpiginous choroiditis, for example. TNF-alpha inhibitors have changed the landscape of uveitis in the last 15 years as steroid-sparing agents. They have found initially to be highly effective in the treatment of juvenile idiopathic arthritis-associated uveitis, but separately in adults, we also have used them for the treatment of non-infectious uveitis in patients who have intermediate pan-uveitis or posterior uveitis that is non-infectious. TNF-alpha is an upstream inhibitor of interleukin-1, which is very important pro-inflammatory cytokine that causes a lot of tissue destruction in many different organs, such as the joint, cartilage, and the eye. So infliximab was the first of these, which was an IV infusion. Infliximab is a chimeric antibody with the human IgG and a mouse variable FC fragment, and fragments on each side. And this is it blocks TNF-alpha and binds to TNF-alpha. Adalimumab is a fully humanized IgG antibody that binds TNF-alpha, tumor necrosis factor alpha, which is, as I said, upstream inhibitor of IL-1. And then finally, etanercept, which is a receptor analog, acts as a receptor to bind TNF-alpha. Unfortunately, etanercept has caused de novo inflammation in patients who never had inflammation when they're utilized. So we don't use it in the treatment of uveitis, and the patients sometimes come to see us who've taken etanercept for inflammatory disease processes, other places in the body that develop de novo uveitis because of this drug. So it's not really better than placebo for the treatment of uveitis. Infliximab and adalimumab has significant evidence, and adalimumab was tested, which is Humira, was tested with a large randomized clinical trials that some of you are familiar with. There are many complications of TNF-alpha inhibitors that you should keep in mind. They can exacerbate demyelinating disease. They can cause congestive heart failure exacerbation. They can exacerbate latent tuberculosis or latent fungal diseases like histoplasmosis. They can cause drug-induced lupus, and they can also cause secondary neoplasia, specifically lymphoma or leukemia. So next polling question. Adalimumab therapy for non-infectious uveitis can cause which of the following adverse effects? I just went over them. Chronic gastritis, demyelinating disease of the CNS, central nervous system, cardiac arrhythmias, or exacerbation of tinea capitis. That's right. So demyelinating diseases that's the most important side effect here that you need to keep in mind. Okay. So demyelinating disease of the CNS is a significant and very particular potential risk factor associated with adalimumab use. Move on to the next one. So adalimumab was studied in a very robust randomized clinical trial looking at control of non-infectious intermediate, posterior, and pan-uveitis in adult patients. Adalimumab was approved in 2016 based on the results of the Visual 1 and Visual 2 studies, which compared adalimumab to tapering doses of oral corticosteroids. What did we find? Well, adalimumab increases the interval to treatment failure from 13 to 24 weeks, and it increases the interval to flare from 4.8 months to 10 months. And there was a substantial and statistically significant difference. It was an 87% increase to the time of treatment failure. I'm sorry, for the treatment failure from 13 weeks to 24 weeks, which is remarkable. And so we know that it's a highly effective agent for the treatment of steroid-sparing agent for the treatment of non-infectious uveitis. Significantly reduced AC cell grade and vitreous haze grade. This study, the visual study, is important because uveitis is a multifaceted disease, right? It's not just about cells and flare. It's about vision. It's about macular edema. It's about a lot of other things. And this trial was very beautifully designed and looked at a lot of different aspects of uveitis management, and really was a home run in the way that it was designed and executed. And it's become a model for future clinical trials in uveitis, as we may see in the next several years. I keep my eyes and ears peeled for those kinds of trials for new agents. So the primary endpoint was the treatment of the treatment failure, and the treatment failure was dramatically the time to treatment failure was dramatically increased with the treatment of adalimumab from this study. I'm going to keep moving here in terms of this. So I've already gone over the conclusions. There were adverse events, but the adverse events in the original visual trials were similar between the steroid group and the adalimumab group. The Visual 3 trials was a follow-up. It was kind of pooled data follow-up. And this showed that, the amount of steroid that patients were utilizing at the end of 78 weeks, which is a longer duration here, was even less. So many of them were on 2.5 milligrams a day of prednisone for maintenance while they're on adalimumab. And patients who had inactive uveitis at entry, they tended to stay inactive on very, very low doses or minimal doses of corticosteroids. So this follow-up data confirmed the efficacy of adalimumab in the treatment of non-infectious intermediate posterior panuveitis. So we also have now data to suggest that and adalimumab is typically given every 2 weeks, but there's also data now to suggest that weekly, for patients who failed every other week, that weekly can improve inflammatory control in more than half of those patients. So this is a retrospective study and a single academic institution, but this is a newer study from Dr. Goldstein's group that showed that weekly adalimumab can also be effective if every other week doesn't work. And even more important than that, there was a placebo-controlled trial looking at adalimumab plus methotrexate versus methotrexate alone. Methotrexate and placebo versus methotrexate plus adalimumab. And what this particular study showed, the Sycamore trial, which showed that this placebo-controlled trial was important because they actually, administered placebo versus adalimumab. And so what they showed was that there was better control with adalimumab plus methotrexate, but patients who received adalimumab had more adverse events. They had adverse infectious events mainly, and these types of serious adverse events required treatment, discontinuation of treatment and treatment of those complications. So that's something important to remember. So this adalimumab therapy controlled inflammation associated with lower rate of treatment failure, but in adolescents and children. But in children with active JI-associated uveitis who were taking this methotrexate plus adalimumab had a much higher incidence of adverse events and serious adverse events than those who received placebo with methotrexate. So that's very important to remember. And it's important when you're giving adalimumab to children that a pediatric rheumatologist be involved in the care of those patients. There are other biologic agents besides adalimumab that we can use for severe inflammatory disease, but these are very toxic agents. The anti-CD20 monoclonal antibody rituximab has been available for several years. It wipes out the B cells, when it wipes out B cells, it's highly effective in the treatment of refractory scleritis and systemic vasculitis such as GPA. It has its role, but it's an off-label use and it's highly toxic. Can produce profound lymphopenia, hypersensitivity reactions, and infusion reactions. There are many other things that are coming out with these with biologic response modifiers that I don't have the time to go through, but many of these are newer agents that provide us with abilities to control inflammation better in patients who have non-infectious uveitis when they've failed the traditional available medications. I've listed a few things here, but I think this is less important. I'm going to try to briefly cover some of the complications of uveitis management. That's changed a little bit too. Uveitic glaucoma is a common complication of chronic non-infectious uveitis. And here you see a couple of patients who have tube shunts from this. Here is a patient statistically significant risk factors from the site studies associated with ocular hypertension. What are the takeaway points here? The importance is that the risk factors for ocular hypertension and glaucoma in the treatment of chronic non-infectious uveitis in the site trials suggested that the patients who had a history of ocular hypertension of the fellow eye are at greater risk for developing glaucoma. Patients who had a history of fluocinolone acetonide implants are at significantly greater risk. Prior or current use of IOP lowering drops, that makes sense. That means they have already issues with glaucoma, so they're going to have problems with intraocular pressures as the studies progress. Patients who are on more than current topical steroid use, especially those who are on very frequent use of drops like 8 or more times a day, they're at greater risk. Periocular steroid use within the last 3 months, they're at greater risk for IOP elevations. People who've had previous ocular surgeries like vitrectomy surgeries are at greater risk. And people who are on more than 7.5 milligrams a day of maintenance oral prednisone, those folks are at greater risk. And if they have structural complications or they have chronic inflammation that is not well controlled, those folks are at greater risk. So all of these are important risk factors for the development of ocular hypertension and glaucoma. And that's something that we know. So it's important to remember that controlling inflammation is important, an important paradigm. Reducing the amount of steroids that the patients are on is an important paradigm for control of intraocular pressures. And knowing a prior history, family history, or propensity for glaucoma is another major risk factor. So here's a patient with a uveitic cataract. This is a very, very bad cataract with bad uveitis that's poorly controlled. Cataract surgery, the MUST trial results show that in this, and remember the MUST is a prospective study that overall patients who underwent primary cataract surgery in the 479 enrolled eyes, overall they did well and the vision improved. And the patients had no preoperative factors for poor pre-op vision had an impact on final visual outcomes. So systemic therapy or fluocinolone implant both had similar visual outcomes in the MUST trial. So if you're on appropriate therapy and you're getting good control of your inflammation, doing cataract surgery in patients who had good control of inflammation on appropriate chronic immunosuppressive therapy and corticosteroid therapy, had good outcomes following cataract surgery. So, if you look at all the patients who have cataract surgery, about 1.2% of patients of all eyes undergoing cataract surgery have uveitis, okay? And if you look at that, they have a higher incidence of ocular copathologies such as glaucoma and small pupils. And this is something that we know in patients who undergo cataract surgery who have underlying uveitis. And they tend to have a poorer visual prognosis overall. So if you look at the general disease process of cataracts associated with uveitis, patients who have uveitis who undergo cataract surgery don't do as well visually. But if they're well controlled, according to the MUST trials, where patients are being seen by uveitis specialists and have good control of inflammation, the outcomes are better. So next polling question, which of the following is not an important risk factor for cataract formation in children with uveitis? Greater number of uveitis flares per year, use of systemic immunosuppressive therapies, presence of posterior synechia, or local corticosteroid injections. So which of the following is not? So this is one of those inverted questions, which is not an important risk factor for cataract formation in children with uveitis. That's right. Systemic immunosuppressive therapy is not a risk factor. In fact, it's protective probably because you're minimizing corticosteroids. Everything else, if they've got a lot of flares, if they're getting steroids, if they've got significant anatomic complications of disease like posterior synechia, they're gonna get cataracts more frequently. So we know that because of a very important study that was done. There are two important studies. So the main risk factors from the British study that showed in retrospective study, the main risk factors for cataract development were number of uveitis flares, presence of other things like cystoid macular edema and posterior synechia, which are structural complications, and the use of local corticosteroid injections. Interestingly, treatment with systemic and topical steroids were not significant risk factors, is what's controlled, what that study suggested. But I think what that study implied was that controlling inflammation, even with using higher dose of steroids, is of importance in preventing ocular complications. So this is important takeaway. However, the next study, that was a retrospective study from the US, showed us from the Hopkins group that when they looked at patients with in children in particular with uveitis, that topical steroid use alone was associated with cataract development, especially when the patients were using 3 or more drops of corticosteroids daily. So 3 is a magic number, okay? So you want to try to reduce the corticosteroid drop usage to 3 or less drops per day in order to help reduce the development of cataracts. Other risk factors include the same kinds of things as you saw in the other study: active inflammatory disease, posterior synechia. They were all associated with the development of cataracts. So that's the authors concluded that topical corticosteroid use of less than 3 drops, less than or equal to 3 drops daily, associated with the 87% lower risk of cataract development in JIA patients, at least. So there are some caveats to what we find with some of these retrospective studies. So there's lots of complications with cataracts and uveitis. And the key for any surgical intervention in uveitis and uveitis patient is get the chronic inflammatory disease well controlled for at least 3 months, and then pulse the patient's topical and oral corticosteroids starting a week before surgery and gradually taper the steroids. You want to avoid doing surgery in actively inflamed eyes because the inflammation is going to really go out of control after the surgery. And you want to be aware and treat all of the inflammation-related complications such as macular edema prior to this. And looking at macular edema itself, the MUSP trials showed us that even when macular edema and uveitis were brought under control, macular edema continues to be a chronic recurrent problem. Uveitic macular edema must be controlled long-term to achieve stable visual outcomes, according to the MUSP trial, the most recent study from 2021. And uveitic macular edema can episodically relapse even when the inflammation is completely clinically controlled. And so these results and these relapses result in significant vision loss. So macular edema in the chronic non-infectious uveitis continues to be a long-term problem and needs to be monitored for patients. So I think that's another important factor. I'm going to stop there. The rest of it is actually parts of other talks that I've given about cataract management, et cetera. I'm going to open it up for questions, but I think that we're towards the end here. And so I don't want to take up too much of your time. I hope that this update was helpful to you and try to bring to light some of the newer studies that I thought were important to discuss. I didn't discuss the Sun group's fantastic reports that were published in the American Journal of Ophthalmology. An entire issue, I think, was dedicated to the Sun criteria. Excuse me, my timer is going off, telling me that I'm done. Okay, there we go. I can't stop this. Okay. All right, there we go. Sorry. So let me answer questions and I'll go to the chat here. And let's see what the Q&A. What to do to decrease inflammation after cataract surgery in a chronic uveitis patient. So first of all, don't operate on a patient who has inflammation. So you want to make sure that the inflammation is well controlled for at least 3 months before you do cataract surgery. That means no cells. To me, inflammation well controlled means no cells. That doesn't mean minimal amount of steroids. Whatever it takes to control the inflammation first, get it done, get the inflammation with 0 cells in the anterior chamber, and then do cataract surgery. If patients have posterior synechia and a lot of flare, they're going to do badly, regardless of how good the cellular control is. And so those patients need to be monitored carefully. use of intraocular lens implants in uveitis patients should be done very judiciously. You know, patients can remain aphakic and wear a contact lens and do better than a patient who has poorly controlled inflammation in an eye with an implant, especially children that ultimately end up needing the implant removed. So it's very important in these cases to talk with a pediatric ophthalmologist, a pediatric rheumatologist, and a uveitis specialist, because these can be very complex cases. What is your preferred method for treating bilateral cystoid macular edema and bilateral intermediate uveitis with little inflammation? Well, if it's bilateral disease, I still prefer to use systemic immunomodulatory therapy. So I use methotrexate or I use mycophenolate, depending on what they need. And if that doesn't work, then I may use intravitreal or periocular corticosteroids for non-infectious uveitis. Sometimes I know colleagues around the country here have used interferon. Interferon has significant side effects, but interferon alpha 2A can be highly effective in cases of the treatment of cystoid macular edema associated with intermediate uveitis. What is the most common cause of scleritis in a 7-month-old baby? That's it. I would look for infectious causes in that situation first, before you look for autoimmune disease causes. That's very rare for babies to present necessarily with scleritis. So I would definitely look for infectious causes. What is, in your experience, has been the maximum duration of steroid therapy for uveitis? I don't know what's meant by that. I have patients who are steroid dependent, who are on 5 milligrams every other day of maintenance oral corticosteroids for 20 years. So, you know, the treatment of inflammatory, chronic and non-infectious inflammatory disease probably requires some corticosteroids. Ideally, we would love to eliminate corticosteroids completely from the equations, but often this is not possible. And we use immunomodulatory therapy to try to minimize the use of those. And remember, chronic diseases require chronic therapy. You don't treat diabetes for one day and say it's cured. You don't treat diabetes for 3 months and say it's cured. It requires chronic ongoing management. Similarly with chronic inflammatory disease. Chronic inflammatory eye disease is disease that lasted more than 3 months without remission. Can you summarize the challenges for treatment of uveitis? I just did. I think I talked about that. So the challenges are trying to reduce corticosteroids, trying to reduce the structural complications associated with the uveitis and the corticosteroids, and balancing that by the use of immunomodulatory therapy for non-infectious uveitis. The other challenge is making sure that you don't miss the diagnosis of infectious uveitis. Is it okay to start treatment with topical steroids only for the first week if the patient shows vitreous? I don't know what ECOS in USG. I'm sorry, I'm not sure what that means. Yes, so if you suspect, I think the question is if the patient may have an implant, if you're thinking that it might be infectious and there's something going on, is it okay to start steroids topically? Yes. In most infectious uveitic cases, you can start topical steroids. The only exceptions are if you have herpetic corneal disease with corneal involvement and epithelial defects in the cornea from herpetic disease, then you will make that disease worse with topical steroids. So that's one exception. Is any recent study for Fuchs uveitis? Nothing recently, other than the most important finding is the association of prior rubella virus and rubella virus RNA was discovered in patients in the anterior chamber who had Fuchs uveitis, and the serologic evidence of a greater prevalence of patients who had exposure to rubella who have Fuchs. So rubella may be the underlying cause of Fuchs. There's some thought also chronic CMV infection can cause Fuchs as well. Dr. Soontaek Chi in Singapore has done a lot of work on this in patients who present with chronic inflammatory disease. It looks very much like Fuchs disease caused by cytomegalovirus. Next, how I can schedule the patient for follow-up for structural and functional control of uveitis? Well, you need to check those patients at least every few weeks, depending on the severity of the inflammation. I check many of my patients on a monthly basis. So somebody said, I have post-RD patient surgery with uveitis for the past 3 months, recurring soon after stopping steroids. What can I do? Well, so in post-retinal detachment surgeries, depending on what kind of surgery was done, if it's a vitrectomy versus a scleral buckle or both, that is not uncommon to see, and those patients can be very difficult to manage. If you have to prove that it's not infectious, first of all. So I would look for, if they have a lot of cells in the anterior chamber, tap the AC and send it off for a PCR evaluation to make sure you're not looking at viral causes. Do it in a laboratory workup also, and a review of systems to make sure they don't have underlying systemic inflammatory disease processes that are non-infectious. And then based on that, I would start treatment with more aggressively than just with topical medications if necessary. Occasionally, it can be because of an inflammatory reaction to an explanted material like a scleral buccal exoplant. If you see scleritis, and the removal of that can make the inflammation better. So this is a very tough problem. What is your opinion about difluprednate use for CMV uveitis? It can be. Difluprednate is an excellent agent to use, but it's not a good agent to use chronically. 50% of patients who use difluprednate will develop glaucoma or severe intraocular pressure elevation, sometimes very rapidly. So that's very important to keep in mind. Difluprednates can be almost as effective as giving a steroid injection in the eye. It does penetrate into the anterior vitreous very well, so it can affect intermediate uveitis treatment positively, and it can affect even cystoid macrodema positively, but it has to be used with caution because of IOP issues. Mycophenolate and methotrexate or second-line treatment fails to control inflammation. What's your next approach? Usually I use anti-TNF therapy for non-infectious uveitis as the second line agent for immunosuppressives, or third line, I guess. For CMV retinitis, immunocompromised patients, when do you decide to stop intravitreal ganciclovir and continue with systemic treatment only? When the retinitis is well controlled and I don't see progression of the retinitis, then I will leave them on maintenance oral ganciclovir, valganciclovir, usually 450 milligrams orally twice daily. What advice would you give a 50-year-old female with recurrent scleral uveitis, long-term steroid drops, and obvious area of scleral thinning? She needs immunomodulatory therapy and needs to be evaluated by a rheumatologist. You also need to make sure that she has P-ANCA, C-ANCA testing, ANA testing, rheumatoid factor testing, and evaluated by a rheumatologist. Next question, what is the most common cause of uveitis in 4-year-old child, infectious or non-infectious? Well, it depends on the presentation. If the patient presents with acute inflammatory disease versus a chronic inflammatory disease where the eyes were white and quiet, if it's bilateral and it's chronic and 4-year-old, it's likely JIA associated. That's the most common identifiable cause. If it's intermediate uveitis, the most common cause is pars planitis. But infectious causes are certainly possible, including toxoplasmosis in the young child. So these are things that you need to consider in a globally as well as in the Western world. All right. So recalcitrant, what do you do in cases of all recalcitrant or all treatment modalities? Maybe I'll refer it to you, the anonymous attendee who asked me that question. I have some patients who have those kinds of problems, unfortunately. We have to do multiple medications. You have to have the help of your colleagues and discuss cases and use things that are off-label and often not utilized regularly. Can the patient free from uveitis be controlled function? Finally, yeah, eventually there are many patients who can be free of uveitis, non-infectious uveitis, but the patients that I see are the toughest cases. So I don't want to say that it's not possible. Certainly it's possible, but it may take years in many cases. What would be a choice of immunosuppression in pregnancy? Azathioprine is a good choice, and TNF alpha inhibitors are decent choices as well. And oral prednisone is relatively safe in pregnancy. All right, well, thank you so much. And I will let you guys go. I hope you have a wonderful rest of the week and weekend. Thank you for your attention. I hope you learned something. I certainly learned something from your questions.